My name's Matthew Mollica. I'm a podiatrist in Essendon at the Windy Hill Podiatry Clinic. I've been here around 17 and a half years. There's a number of different prescription variables that I find myself using on a regular basis when sending orthotic prescriptions off to Arthur. And I'm going to focus for a couple of minutes on two of those, and they're both related to forefoot function. The first is a Forefoot Eversion wedge, and the second is a metatarsal dome. And so they're really shell modifications that are added to the orthotic and the orthotic top covers almost immediately prior to completion of the orthotic. I use these modifications with a couple of specific foot types, a couple of specific pathologies, and for a few distinct purposes. I'll focus on the metatarsal dome at first because that's really a very simple sort of addition to an orthotic prescription and something with which every podiatrist would be very familiar, I'd imagine. I find myself using these little additions to an orthotic prescription in the management of second metatarsophalangeal joint pathology, particularly plantar plate herniations, synovitis, and effusion. And I also occasionally use them when I'm prescribing an orthotic in the management of poor foot posture that is related to the onset and deterioration of a Morton's neuroma. I frequently see that patients demonstrate relatively poor patterns of forefoot load distribution and that they bear disproportionately high loads at their second and third metatarsal heads, and that those associated MTP joints tend not to work as well. They get overloaded, they bear disproportionately high loads, and they bear them for prolonged periods throughout the gait cycle, and particularly so when patients are sporting patients and they're involved with forefoot loading activities like basketball, tennis, even netball and football to some extent. And I find that the inclusion of a metatarsal dome can be really helpful in shifting load from a symptomatic area at the forefoot, but most notably that second MTP joint. I've consistently found that the placement of those domes and the sorts of foams that Arthur uses in their fabrication are really, really helpful, very tolerable for patients in day-to-day shoes, but also their sporting footwear, their runners and football boots. Very rarely find that patients have a difficulty in adapting to them during competition and training, and that they very, very rarely blister or have some sort of shoe incompatibility issue. The second modification that I was going to speak about, Arthur has often referred to or colloquially referred to as a Morarty, really named after Rebecca Morarty, who was a podiatrist who graduated from La Trobe University in the mid-1990s. I think she was probably the first to consistently ask for a forefoot eversion wedge. And most frequently when I employ that sort of orthotic variable, I'm asking Arthur and his team at Footwork to adhere something as an interface between the orthotic top surface and the orthotic shell that is a few millimetres thick and primarily composed of EVA, of a green or a mid to high density. I'm really looking for some sort of lateral midfoot and forefoot control with that sort of addition, something that can help me to support a hypermobile midfoot segment, a midfoot segment with a predominant or a high range of transverse plane motion, or potentially a lazy, if you like, or a somewhat incompetent first column or medial column. Again, I use these for a distinct range of purposes, sometimes lateral instability. I often find that patients who have a history of ankle inversion episodes will respond really well to the presence of a forefoot eversion wedge. I also find that people who have sufficient range at a non-degenerative first metatarsophalangeal joint but need some help either recruiting that joint, if you like, or using it in a more efficient manner, will often benefit from the placement of that forefoot eversion wedge. There was a landmark study that came out many years ago that looked at combinations of heel raises, rear foot inversion and forefoot eversion as an efficient mode of providing orthotic support in the management of plantar fascial pathology, and particularly reducing peak tensile loads on the plantar fascia. And again, that's one other condition where I find the inclusion of a forefoot eversion wedge very helpful. As I was intimating before, I consistently find that that's a low bulk and very neatly included component within an overall orthotic prescription, something that is very tolerable and something that patients find quite comfortable quite quickly. I'll sometimes ask for that at the time of initial orthotic manufacture, but on occasions I'll see a patient who needs an orthotic refurbishment after a few years or simply needs an orthotic recover after a year or two, and I'm also able to include an orthotic modification like a metatarsal dome or a forefoot eversion wedge within that recovering at that time.